So now let's go to the specific drugs or anesthetic agents under general anesthesia. So when we talk about general anesthesia, we can classify or categorize them into inhalational agents and parenteral agents. For inhalational agents, we have the volatile anesthetics and we have the gaseous anesthetics. So for volatile anesthetics, we're going to talk about isoflurane, sevoflurane, desflurane, halothane, and enflurane. For the gaseous anesthetics, we're going to talk about nitrous oxide and xenon only. So for the parenteral general anesthesia, we will be talking about propofol, the barbiturates, etomidate, ketamine, and the different anesthetic adjuncts. So let's start with the inhalational anesthetic agents. We have the volatile anesthetics. So the first is isoflurane. So isoflurane is typically used for maintenance of anesthesia after induction with other agents. This is because of its pungent odor. It produces a concentration dependent decrease in arterial blood pressure, but the cardiac output is well maintained. So hypotension is the result of decreased systemic vascular resistance. Isoflurane also produces concentration-dependent depression of ventilation, and it causes bronchodilation. It's a bronchodilator. However, it is also an airway irritant and can stimulate airway reflexes during induction of anesthesia. So it produces coughing and laryngospasm. So these are some things that the anesthesiologist using isoflurane has to consider in a patient. So this is your isoflurane liquid for inhalation. It is placed in the anesthesia machine and given to the patient through inhalation. We also have sevoflurane. So sevoflurane is widely used for outpatient anesthesia because of its rapid recovery profile and because it is not irritating to the airway, even if it is a potent bronchodilator. So it produces concentration-dependent decrease in arterial blood pressure due to the systemic vasodilation, and it also causes decreased cardiac output. However, it does not produce tachycardia, so that's why it may be the preferable agent in patients who are prone to myocardial ischemia. This is your sevoflurane. It is also in liquid form and given to the patient through inhalation. We also have desflurane. Desflurane is used for outpatient surgery because of its rapid onset and rapid recovery time. However, it irritates the tracheobronchial tree and can provoke coughing, salivation, and bronchospasm. That's why it's usually induced with an IV agent. Also, its emergence is rapid, so that's why it's also being used for outpatient surgery because of the rapid emergence after the surgical operation. And it also produces hypotension primarily by decreasing systemic vascular resistance, just like the previous agents. So this is your desflurane. Just like the previous drugs, it is also in liquid form and given to the patient through inhalation. We also have halothane. Halothane is used for maintenance anesthesia. However, halothane causes hepatotoxicity. That's why its use is limited. So it can produce fulminant hepatic necrosis or halothane hepatitis in patients given this drug. Halothane hepatitis causes fever, anorexia, nausea, vomiting, and has a fatality rate of 50% a few to several hours after use of halothane. So this is halothane. So it is also in liquid form and given through inhalation. And lastly, enflurane is used for the maintenance. It's also for maintenance of anesthesia, but its use is limited also because of nephrotoxicity. So it causes a decrease in BP which is the result of vasodilation and depression of myocardial contractility. And it can produce seizures and should not be used in patients with seizure disorders. This is enflurane. So by the way, this is how your anesthesia machine looks like. So actually, the anesthesia machine is only this part. Here below, these are drawers where you can place medications and other equipment. And this one is your cardiac monitor for the monitoring of the patient. These are the bellows that are attached to the anesthesia machine. So this will be used to bag the patient, much like an ambu bag or a bag mask device. But the tubes are connected to the anesthesia machine here. And these are the knobs that control how much gases are given to the patient for inhalation. So the liquid medications are actually placed here where they are aerosolized and given to the patient to inhale. If you notice, there are color coding schemes. Purple is for isoflurane and yellow is for sevoflurane. Now at the back of the anesthesia machine, you will find a lot more tubings and usually you will find the gas tanks. The tanks are usually color coded for the gases that they contain. For example, oxygen is usually in a green tank. So let's now proceed to the gaseous agents. The first is nitrous oxide. It's one of the oldest. So nitrous oxide is a weak anesthetic that has significant analgesic effects. Surgical anesthesia is only achieved under hyperbaric conditions. A major problem with nitrous oxide is that it will exchange with N2 in any air containing cavity in the body. So this increases the volume or pressure in the cavity that it escaped from. So for example, a patient has a pneumothorax or an obstruction in the middle ear or an embolus, an air embolus, or a loop of bowel that is obstructed, or even intracranial air. So these are examples of air collections that can be expanded by nitrous oxide. So the use of nitrous oxide should be avoided in these clinical settings. The clinical use of nitrous oxide is controversial due to the potential metabolic effects related to increased homocysteine and changes in DNA and protein synthesis. So that's why it was a relief that the fluorinated hydrocarbons or the fluorinated inhaled anesthetics were discovered or developed. Another gas used as anesthetic is xenon. However, it's a very rare gas that cannot be manufactured and it must be extracted from air. That's why it is very expensive. So this limits the use of xenon. It also has, sayang lang because it has minimal cardiorespiratory side effects. Now, the analgesic and anesthetic effects are due to non-competitive antagonism of the NMDA receptor and agonism at the TREC channel. So the TREC channel is a member of the 2,4 potassium channel family that we talked about earlier. So these are thought to be the central mechanisms of action of xenon. So now let's talk about the parenteral agents. So these are still general anesthetic agents, but they are given parenterally. Okay, the first and the most common is propofol. It's the most commonly used parenteral agent or parenteral anesthetic. So it is highly lipophilic. So it is able to enter the brain and the spinal cord and accumulate in fatty tissues. So propofol should be administered within 4 hours of removal from packaging. This is because it causes lipid emulsion formation. And if you give this after 4 hours of removal from packaging, it causes significant pain on injection and it causes hyperlipidemia. Propofol is often used for induction and maintenance of anesthesia. as an alternative to inhaled anesthetics. The adult induction dose is 1 to 2.5 milligrams per kilogram, and the dosage should be decreased in the elderly due to reduced clearance. And it also should be increased in young children, or if you give it to young children, because of rapid clearance. Aside from being used for induction of anesthesia, propofol is also used for sedation. So, for a sedating dose, you usually give around 20 to 50% of the general anesthetic dose. So, the presumed mechanism of action of propofol is through the potentiation of the chloride current mediated through the GABA A receptor complex. Propofol is a potent respiratory depressant, and it can cause apnea if you give more than what is needed. Propofol also has antiemetic properties, so this can also be given to prevent or to treat vomiting. Did you know that propofol is also this is also called milk of magnesia? So it looks like milk, and also this is also the drug known to have been given to Michael Jackson before he succumbed. They say it was an overdose of propofol. So maybe he was being given propofol shots because he was known to have insomnia. So because this is a sedative, that's why he was given propofol. We also have thiopental and methohexital. So these are the barbiturates or the hypnotics. So they have been largely replaced by propofol as induction agents. This is because also barbiturates are likely to be abused. So it has effects on inhibitory transmission, probably from activation of the GABA A receptor complex also. Effects on excitatory transmission are less well understood. So these barbiturates produce dose-dependent CNS depression ranging from sedation to general anesthesia when administered as bolus injections. They do not produce analgesia. Instead, some evidence even suggests that they reduce the pain threshold, causing hyperalgesia. Now, thiopental sounds familiar, doesn't it? I'm sure you heard of this drug before. Thiopental is known to have been used before during interrogations, specifically torture interrogations, which makes sense because it causes hyperalgesia. And as a hypnotic, it also seems to get the truth out of the one being tortured, thus the name truth serum. Although there are also other drugs called truth serum, thiopental is one of them. So these drugs are useful in management of patients with space-occupying intracranial lesions because of its ability to decrease intracranial pressure and cerebral metabolic rate. So it may provide neuroprotection from focal cerebral ischemia, such as stroke, surgical retraction, or temporary clips during aneurysm surgery. But it cannot protect against global cerebral ischemia, for example, that one caused by cardiac arrest. Barbiturates are respiratory depressants, so they may produce transient apnea. Also, it's important to take note that mixing barbiturates with drugs in acidic solutions during anesthetic induction can result in precipitation of the barbiturate. So that's why you should not give barbiturates with other drugs in the same IV tubing. So ideally, you should give barbiturates in a different IV tubing or intravenous tubing. Or if you only can do one, or if you can only use one IV, so you have to make sure that the barbiturate has cleared the IV tubing before giving other drugs. Compared to propofol, barbiturates produce a higher incidence of wheezing in asthmatics. So this is another thing you have to consider, or this should be avoided in asthmatic patients. This is attributed to histamine release from mast cells during induction of anesthesia. Okay, so we also have etomidate. So etomidate is a hypnotic, but it is not an analgesic. So it is chosen for its minimal hemodynamic effects. So it does not cause instability of the cardiovascular system. It has minimal changes on the heart rate and the cardiac output. So that's why it is preferred for patients at risk of hypotension or patients at risk of MI. So etomidate appears to have GABA-like effects and seem to act primarily through potentiation of GABA-A mediated chloride current also, just like the previous anesthetics or the previous IV anesthetics we discussed. So etomidate has no neuroprotective properties. In fact, it increases EEG activity and it is associated with seizures. So this is an anesthetic to avoid in patients who have seizure disorders. Its use is also limited due to the endocrine effects. So it actually causes adrenocortical suppression by the inhibition of 11 beta hydroxylase. No? So if you remember, this is an enzyme that is necessary for the conversion of cholesterol to cortisol. So this adrenocortical suppression lasts for 4 to 8 hours after the induction dose. Etomidate is an alternative to propofol and barbiturates in patients with compromised myocardial contractility. Again, it does not produce analgesia, and post-op nausea and vomiting are common. Ketamine is useful for anesthetizing patients at risk for hypotension and bronchospasm. So the major effect is probably produced through the inhibition of the NMDA receptor complex. Ketamine, however, produces dissociative anesthesia. So this is a characteristic state observed after an induction dose where the patient's eyes remain open with a slow nystagmic gaze. So this is what we call the dissociative anesthesia. It is a cataleptic state. So the patients have profound analgesia. They are unresponsive to commands. They have amnesia, but their eyes are open. They can also move their limbs involuntarily, and they breathe spontaneously. Another drawback, another downside of ketamine is that upon emergence from the anesthesia, patients experience emergence delirium, which is characterized by hallucinations, vivid dreams, delusions, out of body experiences, and increased and distorted visual, tactile, and auditory sensitivity. So that's why it causes serious patient dissatisfaction and it can complicate post-operative management. So that's why it's not a very nice drug to use. So ketamine also produces transient but significant increases in systemic blood pressure. So you do not want to use this in patients who have cardiovascular problems. So it can also increase heart rate and the cardiac output, maybe because of centrally mediated sympathetic stimulation. So the upside of ketamine, though, is that it can be administered by multiple routes. So it can be given IV or IM or oral, rectal, or epidural. So that's why it is a useful option for pre-medication in patients who are mentally challenged or patients who are uncooperative. So let's also talk about anesthetic adjuncts. So these are drugs that are given alongside general anesthetics to augment specific components of anesthesia. So this is done so that the general anesthesia dose is lower. So thus there are fewer side effects. So the first group of adjuncts are the benzodiazepines. So you have midazolam, lorazepam, and diazepam. So these drugs can produce anesthesia similar to that of barbiturates, but they are more commonly used for sedation rather than general anesthesia because the anesthetizing doses may cause prolonged amnesia and sedation. The most desired effects of benzodiazepines are relief for anxiety and anterograde amnesia. So these are useful for pre-medication in patients who are anxious for their upcoming surgery. So this can be given to patients before surgery. So benzodiazepines are highly lipid soluble. So they rapidly enter the CNS and they have rapid onset of action. They also have minimal depression of ventilation. However, transient apnea can follow after rapid IV. So benzodiazepines are commonly used for perioperative medication, IV sedation, and suppression of seizures also. Benzodiazepines are unique among the group of IV anesthetics in that their action can readily be terminated by administration of flumazenil, which is their selective antagonist. So, for example, the anesthesiologist gave midazolam, and then when the surgery is done, so say the patient can now be brought or transferred to the recovery room, the anesthesiologist can give a dose of flumazenil to reverse the effects of midazolam. The most commonly used is midazolam, which is used for pre-medication and for sedation during regional anesthesia and for short or brief therapeutic procedures. It actually can be used for general anesthesia also, but the disadvantage is the patient will have delayed awakening and also prolonged amnesia and sedation. So another type of drugs used as adjuncts are alpha adrenergic agonists. So we only have one example, dexmedetomidine. So this is used for short-term sedation of critically ill adults and for sedation prior to and during surgical or other medical procedures in patients who are not intubated. So they act by activation of the alpha 2 adrenergic receptor and it produces both sedation and analgesia. Common side effects include hypotension and bradycardia, which are attributed to the decreased catecholamine release by activation peripherally and in the CNS of the alpha 2A receptor. And we also have neuromuscular blocking agents. So we have the depolarizing, for example, the succinylcholine, and non-depolarizing muscle relaxants. We have the atracurium and vecuronium. So these muscle relaxants are often administered during the induction of anesthesia to relax the muscles of the jaw, the neck, and the airway. So this helps the anesthesiologist do laryngoscopy or endotracheal intubation much easier because the muscles of the jaw, the neck, and the airway are relaxed. So it is much easier to insert the tube. The action of non-depolarizing muscle relaxants usually is antagonized once muscle paralysis is no longer desired. The anesthesiologist usually gives an acetylcholinesterase inhibitor, for example, neostigmine or edrophonium. Also in combination with a muscarinic receptor antagonist such as atropine to offset the muscarinic activation resulting from esterase inhibition. In other words, if you want to reverse the effects of the neuromuscular blocking agents because maybe the surgery is done or you already extubated the patient, you can give neostigmine and atropine.